Hello, nerds!
Hello, nerds!
Adlah Sukkar, thank you for coming on to the show. We have a mutual friend who was saying, wow, a buddy of mine is a doctor, and she was sharing some pretty interesting insights around the whole kind of COVID crisis from a doctor's perspective. And then I said, oh, well, can we get her on the Nerds for Humanity channel? And here you are. So first of all, welcome to the show.
Thank you for having me.
Why don't we just start with a little bit of background as to, where you're joining us from and what you do for a living, and then we can get into the details.
Sure. So I am originally from Louisiana. I moved up to Maryland to go to med school at Hopkins, and I stayed there through my training. And I'm in private practice for the last 10 years in Northern Virginia, primarily practicing out of Fairfax Hospital, a big tertiary care hospital center. And I'm an adult pulmonologist, so basically a doctor who takes care of lungs. I'm also boarded in intensive care unit medicine as well.
Well, so you are kind of probably seeing firsthand some of the impact of this COVID stuff, given the lungs specialty. Tell us a little bit about what it was like when it first kind of showed up on your radar, and how you kind of started to discover this is a thing. And
I think we all felt like a wave was coming. We all knew it was coming. I think Italy was a big wake-up call, in particular from Northern Virginia, that, okay, guys, we got to get ready. This is inevitable. There was a lot of second guessing of looking back at cases where, we had people coming in with viral illnesses and they were flu swab negative, and you just started to question, you really started to question, and then it honestly felt like a tsunami kind of hit. It was pretty overwhelming, and you just felt the cases just building and building and building. It was pretty chaotic for quite a while. We had, I would say within our hospital system, we had a pretty concerted effort amongst the hospital, the private physicians, everybody really trying to come together to try and kind of tackle this. But, it was so new, despite everything we were seeing coming out of China, coming out of Italy, in terms of trying to prepare ourselves, trying to decrease elective cases, trying to secure equipment. I think probably when it was first starting, one of the most frustrating things was the turnaround time on testing. That was really difficult. It was very difficult, both in terms of knowing what to do with patients, but also just how to think beyond. We were all kind of wearing COVID goggles, is how I would say, because we knew so very little. People would come in, they would have flu-like symptoms, but you needed to test them for COVID, and you were waiting and waiting and waiting. I remember a patient in particular, we waited, I think it was 7 days to get a test back. And in the end, she didn't have COVID, as it turns out. But her evaluation for things that were non-COVID were absolutely stymied. Because we couldn't take her out of the room.
Yeah.
We couldn't do imaging. She needed biopsies of lymph nodes. We couldn't do anything. So we literally felt like our hands were tied in terms of giving her the care that she deserved and care that we would have given under any other circumstance. So that was in the beginning. But to be frank, after that, everything was COVID. I feel in a normal situation, my practice is a pretty big practice. We're the biggest pulmonary practice that works out of Inova, Fairfax. And on a typical census on inpatients specifically, I'm talking about, in the 30 range, mostly because the internists are very, very good. They can handle a lot of things without needing our consultation. But we were hitting 40, 50 patients, and like 98% of them were COVID positive. So it was tough. It was emotionally tough. It was physically tough. You know, very long days. You would the process to get in and out of a patient's room is cumbersome. And so when you multiply that by all these patients, you know, the physical toll, the emotional toll. Did I do it right? Did I put on my PPE properly? You know, those were all big things. I think, you know, as things went on, we felt more comfortable in terms of our process, I guess I would say. But I mean, we even had situations where we weren't necessarily consulting on the patients directly, but we were doing what we called COVID rounds, where there would be entire floors of the hospital dedicated just to COVID patients. And we would do like walk rounds with our hospitalists to try and identify the patients that we felt were at high risk for decompensation, just simply because there weren't enough bodies, there weren't enough of us to actually take. No, I think we did a great job under the circumstances, and it was a very like moving sort of target and a moving sort of strategy. But, you know, we're rounding on, you know, in addition to those patients I was referring to, an additional 50, 60 sort of patients, just trying to catch these patients before things really took off. You know, we have a situation where you have patients who may be petering along in the very beginning with cough, fever, shortness of breath, low level of oxygen compromise. And in a matter of 12 hours, they were in the ICU intubated.
Wow. And what you said at one point, you were doing a special set of rounds to identify patients who had a high risk of decompensation. Was that the term?
Yeah. So, you know,
what does that mean?
So what I mean by that, so what we were starting, it took a while, but what we were starting to recognize is that, you know, there were a lot of patients who, let's say by way of example, you had a patient, they came in, if they were lucky enough, they were able to get a test. I'm talking about in the beginning of things, okay? They were swabbed and told, go home. You don't have an oxygen requirement. There's nothing more that we can do. And you can just go home, quarantine. I mean, everybody kind of heard that message. And we were starting to see patients coming in on like day 7, 8, 9. And that's when the really intense inflammatory response from the virus was really hitting. And so we were seeing a lot of patients coming back in now with an oxygen requirement, now with a chest x-ray that was markedly worse than when they first came in. And we were seeing that even though in patients that had been admitted, let's say they were mildly hypoxic, meaning low oxygen levels, but they hit this like cytokine storm, we call it, and the rapidity at which they can decline from needing 1 liter or 2 liters of oxygen. I mean, we would round on these patients. We'd have morning COVID rounds and then afternoon COVID rounds. And you would see vast changes between the morning, the 9 a.m. and the 2 p.m. rounds, where patients were going from needing maybe 2 liters to all of a sudden they're on 8 liters, to they're needing what's called a high flow nasal cannula, to they're needing to go to the intensive care unit to be intubated. You know.
Wow.
So we were trying to catch those patients so that we weren't in like code situations, you know, because one, for the patient, obviously, but 2, for the safety of the staff. In terms of, I mean, running a code on a COVID positive patient is a very high risk situation. Intubating a patient in an emergent setting rather than in a controlled setting is a very different situation.
I remember when this started catching a lot of people's attention, there was a counter interpretation, which was that, you know, it's a bad case of the flu.
Right.
And what you're describing, I mean, I know people die from the flu as well. How would you sort of react to the argument that, well, you know, it's a virus. We have viruses all the time. Flu kills tens of thousands of people. This is like another one of those.
To me, this is very different. This is completely uncharted territory. And it's not just because of the respiratory failure that we're seeing, which is profound. The amount of lung destruction that we're seeing, the amount of the effects from this pro-inflammatory sort of state that we're seeing, you know, kidney failure, young people who are otherwise not having symptoms of COVID from a lung standpoint, presenting with stroke, okay? Vascular complications. So what I mean by that, I'll give you some examples. So I, you know, had a patient who COVID positive at one point had quite involved lung involvement, recovered from that, but he was absolutely delirious, okay? And we couldn't attribute that to like an ICU phenomenon, which we do see in a lot of patients where if you've been in an ICU for a prolonged period of time, you've been on medications, there's just like what we call a metabolic encephalopathy simply because of your infections, those sorts of things. You can see like a post-ICU sort of syndrome. That was not the case in this gentleman. He was very confused, and to the point that we couldn't safely downgrade him out of our intermediate care unit out onto a floor because he had to be on medications to address that severe agitation and delirium, those sorts of things. So what was really striking to me about his case was that he was, as COVID went along, we started to recognize this like pro-clotting sort of phenomenon. So it all goes along with that inflammatory cascade from this virus that gets set off. And one of the things is that can make you, the phrase is hypercoagulable, meaning that your blood wants to clot more, okay? And so we started putting patients prophylactically, trying to prevent clots on blood thinners, which is a typical sort of process in a hospitalization simply because patients are relatively immobile when they're in a hospital situation. But even on higher doses, because of some of the lab tests that we started seeing coming back, and we started to see, you know, clots, et cetera. So in this gentleman, lungs were recovered. He was fine. He was on room air, okay? He was on full dose prophylactic blood thinners. He was having neuro changes. And then about 2 days after I went off service, one of my colleagues was taking care of him and his foot went completely pulseless. So he had clotted off an artery in his leg and it was amputated that week. And that he's certainly not the only patient that we had that happen with. So to kind of get back to your question of, is this the flu? No, this isn't the flu. I mean, the vascular complications that we're seeing, some of the profound low oxygen issues that we're seeing, the neuro issues that we're seeing, I personally have never, I mean, I don't think any of us physicians have dealt with anything like this.
How well do you think we understand this thing now? It sounds like in the early days, we were still trying to figure out, you know, what it did and how to deal with it. Do you feel now that we've got a good handle on?
No. I think the more data we gather, the more we actually are becoming aware how little we actually know. You know, there was a article that came out, I believe it was in the Washington Post or not that long ago, about an autopsy study looking at brain, kidney, lung, heart from about, I think it was 87 patients who had died from COVID. And, you know, we're the micro clots in many organs. Areas of what we call ischemia, meaning deprivation of oxygen within the brain, okay? Not necessarily due to blood clots, okay? This is just simply oxygen didn't get there. We have a lot of concerns about patients who were fine, not fine, but came into the emergency room, swabbed, did not have an oxygen issue, went home as they should have and were directed to do, but got potentially pretty hypoxic, low oxygen levels. We don't know what that's going to mean for them long term. We don't know that yet. Increasingly, I mean, I'm not a neurologist, but I have colleagues that are neurologists, and increasingly there are concerns, are we going to see 30 years from now a cohort of people who have early onset dementia, neurocognitive problems? We don't know. I'm not trying to be an alarmist, but it's just to say, to insinuate that we have any idea about the long-term complications. I mean, right now, when we're talking about long-term, we're talking about in the order of weeks in terms of what we're seeing. We don't know years from now. There's plenty of people who've, they've had kids that they've done imaging on in other countries where completely asymptomatic, but had abnormalities on their chest x-rays. Do we know yet that those are resolved? Are these going to be people with scars in their lungs? I can't answer that for you.
Okay, so I'm guessing there's probably people watching this now who are thinking, holy crap, this could be really, really serious. And it doesn't sound like, oh, if you get it, you test positive and then you recover, that you're like out of the woods forever.
No.
Like,
no, I don't think we know the answer to that question. I mean, I'm gonna give you an example of a patient I had. Okay, 23 years old, medical tech, like a technician in a hospital. Okay, not my hospital, but a different hospital. It was in the beginning of the pandemic when we didn't have great protective gear. She and 4 colleagues, other techs, I believe, I'm not sure, had a bad exposure. All 5 of them contracted it, according to her. I can't confirm or deny that. She came to me because she had gone and gotten swabbed at a third facility and was not hypoxic, meaning her oxygen was fine, and was told to go home and isolate. So she did that. She happened to have a pulse oximeter. So she was measuring her oxygen levels at home. She started to have problems. She was very short of breath. This is a 23-year-old who was a 10-mile-a-day runner with a resting heart rate in high 40s because she was so well conditioned. The long and short of it is that she ultimately made it to see me. And I will tell you, she had to have 2 negative COVID tests before we could safely bring her into our hospital. So you can imagine some of the difficulty of like trying to help people when they don't meet criteria for being in the hospital, but yet you don't quite know how to safely bring them into your outpatient practice without putting yourself, your staff, and your other patients at risk. And the good news for her was that she did not, at that point, by the time I saw her, her oxygen issues had resolved. Her imaging, her chest imaging, was actually normalized. But this girl was short of breath, extremely short of breath. And the reason is because she couldn't walk across my office without her heart rate hitting like 160. Okay? And I had no explanation for it. I sent her to a cardiologist. And the best thing that we can come up with is that the virus has caused like a dysautonomia, like an effect on how her nerves control her heart rate and some of the other sort of basic functions in her body. And so she's under the care of a cardiologist now. She's on medication to slow her heart rate. But I don't know long term, is she going to be able to come off of that medication? Is she going to be able to regulate her heart rate? Is she going to be a runner again? She's having problems with insomnia, headaches, these profound fatigue, those sorts of things.
You touch on another topic that relates to a lot of people's understanding of this problem, which is, I thought And I thought even the data showed that most of the fatalities were occurring with much older people with pre-existing, other conditions. The example you gave obviously was not someone in a nursing home, but a 20-something-year-old runner. How was that? Are you seeing like a material number of people not in their 70s?
No, I wouldn't say, and so, I mean, and I think this is one of the messages that I kind of want to get out there is that, we can talk about mortality, which is death, and we can talk about morbidity, which is what's your quality of life. Okay. And so the data you're correct in terms of the mortality data. Okay. But we're not collecting, or we don't have a great sense at this point of morbidity data. Okay. So, you've got this cohort of people who recovered and we think they're fine. And I hope they're fine long-term. We've got a cohort of people who have passed away from very severe cases. And then we've got a section in the middle ground where we already know right now they've managed to survive. But what is their life going to look like? And that's what I think people are kind of missing the boat on a little bit. I have several patients who are still admitted in the hospital now. We're hitting like day 70 plus of hospital admission. And these are people who I can't replicate the amount of oxygen it would require outside of a hospital setting for them to leave.
Oh my God.
Okay. So these are patients who were normal. One was an Uber driver. Okay. I think he's like 48. Okay. And he had a very severe case. And he will leave this hospital when he either gets a secondary complication or he gets a lung transplant.
Okay, so let's talk about prevention. Clearly, I mean, let's maybe for argument's sake, I'm pretty convinced you're a trained Johns Hopkins doctor, specialist in lungs. You've been working with patients now for months. So let's just stipulate that it is a big deal. It's more than the flu. It can have major negative implications, even if you're not obese and in your 70s. You could just be
Absolutely.
Right.
Let me just throw this out there. Let me just throw this out there too. I didn't take care of these patients personally, but I will tell you that we don't think there's a lot of morbidity in kids, but in my hospital there were 3 teenagers, 2 16-year-olds and a 14-year-old who are on ECMO. Okay.
What's ECMO?
ECMO is extracorporeal membranous oxygenation. So basically taking the blood out of the body, giving it oxygen and putting it back in the body. Okay. It's about the most aggressive thing that we can do to try and save somebody who's in hypoxic respiratory failure. Okay. 2 of them ended up with tracheostomies. So yes, they're alive. Okay.
Yeah. How are you when you're off work and you're just trying to live a normal life? What precautions are you taking? I mean, clearly you're convinced this is a big deal, but you also have to.
No, absolutely.
live.
I have to go about my life, and I have kids, and so I mean, I wear a mask. I don't wear gloves, but I wear a mask. I wash my hands. I don't touch my face. And I'd say the advice I give to myself, the advice I've given to my teenage stepson, the advice I've given to my patients is if you go out and you feel uncomfortable in a situation, let's say you go somewhere and you feel comfortable initially, but then the situation changes, leave. Like I've left places before when I have gone from feeling comfortable with my surroundings to uncomfortable with my surroundings. I believe in distancing and social distancing. I believe in hand washing. I believe in wearing a mask. I mean, when I'm in the hospital, I have the benefit of a big respirator. Okay. So I actually watched your brother's from a while back, and it's very similar to what he has. But I have the benefit of that. I have the benefit of the PPE. I mean, I hear you. Like in the hospital, I actually feel good, about where things stand now. Okay.
Mm-hmm.
I'm more scared going to the grocery store.
Yeah.
More concerned about somebody getting into my personal space without a mask on. I mean, I feel we're very fortunate in Virginia and in Northern Virginia, and that people are really taking things seriously. We have a governor who is a physician. I think we're really fortunate in that respect. I've seen things change through the weeks in terms of masking. I was very concerned in the beginning, especially because there was a disproportionate number of our Hispanic population. That community, the Latino community, was just being decimated in the beginning of this pandemic. And I think it was because of multi-generational living situations, close quarters, the inability to stay home from work because of being either essential workers or, for whatever reasons, lack of access to preventative care. So people with underlying, maybe undertreated hypertension, diabetes, etc. And we saw a lot of people who, there was like people who worked in the construction field within a family where there were many generations and family members. And I was particularly concerned because I wasn't seeing masking amongst these workers that I would see as I was driving in to the hospital, for example. And it was quite numerous, even though these were like, I believe, contractors, from the state, et cetera. And I mean, so it was disconcerting. Anyway, all that to say that everybody that I'm seeing now is wearing a mask, at least where I'm living.
Yeah. And when you mentioned advice about when you're in a situation and you're not comfortable, like remove yourself from the situation, can you give an example of when that might have happened to you, and like what are the signs for when someone should kind of expand their perimeter?
Well, no, I mean, I don't feel like it's as much going on right now, but there have been instances where I walked into a grocery store. I was one of the few people masked. I left. I'm not going to shop there.
Yeah.
That's a very simple example. But, for other people, like, let's say that you go, let's say you're under the impression that you're going to go to like a park or something, and it's not going to be very crowded, and even an indoor sort of a situation, and you don't believe it's going to be crowded, but it's crowded, I would leave.
Mm-hmm. And what's your take on, I think a lot of us hope that being outdoors is sort of a safer environment than inside?
I mean, I think based on the data that we have, I would agree with that. Yeah. Having said that, do I think you should go and park yourself on a beach where you're literally like umbrella to umbrella? No.
Mm-hmm. And what's your take on, I've seen many people with different types of masks, like the surgical and then the N95 ones. And lately I've started seeing people with like these clear plastic kind of face shield things. Mm-hmm. Do you have any views on?
Yeah, I mean, so so face shields is protecting, it's protecting your eyes in addition to your mouth and your nose. And so I think that's a good strategy. With respect to the cloth, there's some thought that double barrier, so 2 layers of cloth, almost like a tea towel sort of cloth, would be superior to just like a single layer versus like a surgical sort of mask. I certainly, think that if you have the benefit of having an N95, then you're protecting not just those around you, but yourself, okay, because of the filtration. Mm-hmm. That we're talking about. But certainly any sort of barrier, I think we feel all comfortable saying is better than nothing at this point.
And do you go full N95 when you're out in the grocery store, or do you do the surgical?
No, I don't.
Yeah. Why not?
I mean, I have on occasion because it's what I happen to like have in the car, you know, kind of a thing. I would say in the beginning when it wasn't so prevalent to wear a mask, I was doing that more. But now that it's a very unusual thing where I'm living to see someone in an indoor space not wearing a mask at this point.
Yeah, I think that one seems to be really dependent on what part of the country you're in, right?
Oh, absolutely.
Yeah.
My family's from Louisiana, you know, and so I talk with my parents very frequently, and people are masking more, you know, but there has been some reluctance to that.
One of the hot topics now is school reopening. What's your take on that?
Ooh, that's hard. It's a really hard topic. You know, I mean, part of it is because we have some data, but we don't have a lot of data. So, you know, for example, in Fairfax County, which is where I am, they're offering an option. We're one of the biggest school districts in the country of 2 days of in school versus 4 days of virtual. It's been like an angst-filled couple of weeks, like trying to decide what we were going to do. I mean, I would say on a personal level, we ended up going virtual, but it was for very particular reasons. I have a child who has some lung conditions that I'm just not willing to take a chance on just yet, not ever, but you know what I'm saying, with respect to what we know. I also feel like those of us who can support a virtual option are actually helping the community by decreasing the number of kids who would physically be in school for those people who don't have that option. So from like a community standpoint, I feel like it's the right thing to do, personally, because I feel like there are certainly many, many people who just absolutely don't have the option of keeping their kids. I mean, look, I'm a 2-physician household. This is not going to be easy, okay? But we're going to figure it out. I hope I've made the right decision for my kids with respect to their education, to their emotional well-being. It helps to have several kids so they're able to play with each other. I'm not in the situation where some families have very, very legitimate concerns about their kids' emotional well-being. And so I think it's a very, very personal decision. I mean, I would say that, you know, PPE, when done right, is effective. Okay. I mean, I'm in a study, all right, and I have been tested multiple times. I'm negative. I have never yet had antibodies. Okay. I mean, I've been all but swimming in it. Okay. I mean, and so all that to say that, you know, but I've had the benefit of a respirator, which is for, you know, lay people more like on the idea of like an N95. Okay. But better. So I've had really great protective gear. So you translate that into the school system, and, you know, there is great data out of, you know, I believe it's out of Japan where, you know, mask plus face shield, you're talking like 97% in terms of protection, if I have my numbers right. But then the question becomes enforceability. You know, is a 5-year-old going to wear a mask all day long? I don't think any of us know that. We're all trying to do the best we can with, you know, very limited data. So it's hard. It's a hard question.
I think you do raise a good point. I haven't heard of this one talked about as much in terms of for those families that are able to accommodate remote learning, doing so may make the on-site experience for families who have no other choice much more viable. Because I guess if everybody goes on site and it doesn't, it results in like overcrowding, then they'll probably just eliminate it entirely, and then those other families are totally screwed.
Yeah. I mean, to be fair, they've said that the system that they have in place was with the concept that 100% of the kids would go back. And that's why they chose 2 days in Fairfax County, so that half of the kids would go for a few days, half would go for. So the thought being that they could accommodate the entire school population. I guess in my mind, though, I just feel like there's more wiggle room if, in terms of not having perfect social distancing, if there's physically less bodies. Or if that means that they can bring those kids back into the schools 3 days a week instead of 2 days a week.
Right.
Have the physical space, to do it. So
yeah,
it's hard.
Well, this is uncharted territory for a lot of us. I guess we'll take it one day at a time. A lot of us are eagerly reading the news for developments of a vaccine.
Absolutely.
And I'm almost afraid to ask this, but I don't know. I kind of feel like if we get one and it's proven, then we're out of the woods, or I have a feeling you're about to tell me no.
I don't know. This is coming at such a rapid pace that, we're all banking on the idea that nothing is being compromised in terms of the studies and in terms of the rapidity at which we're trying to get this out. So with bated breath, I'm cautiously optimistic that a vaccine will, it's what we're all waiting for. So we'll see.
Yeah, it's such a delicate one. I was talking to a friend about this, and we were like, oh, we heard like Moderna is doing okay and the Oxford thing's going fine. And I also was listening to another podcast where Axelrod I think he was telling Yang that no matter what, we will announce a successful vaccine before the general election, like irrespective of whether we have one or not. And it made me wonder, like, okay, I'm all for fast tracking, and I'm all for removing kind of any like unnecessary red tape.
Mm-hmm.
But there are some like processes and requirements that are there for our protection.
Absolutely.
Yeah. So we'll really have to hope that people are exercising good judgment on what they approve.
Right. In terms of side effect profile well, I mean, obviously we want it to be an effective vaccine, but we also don't want it to cause more problems.
Yeah.
In terms of side effect profile or any sort of immunologic response, et cetera. So,
I mean, this is such a terrible dilemma. Like if you rush it and it doesn't go well, then you could end up where people just reject all, to say, oh, I don't want any more vaccines.
Right. You chip away at any sort of capital you have to buy in to the concept of vaccination and broad vaccination.
Yeah.
That's not even getting towards who's going to have access to the vaccines and equitable distribution of vaccines, et cetera.
Yeah.
So
nuts. Let's make believe that we do develop a safe, effective vaccine in a timely way, and it gets distributed. Is your sense like, well, we just had this kind of like black swan event, this sort of once in a long while event, and now we go back to Super Bowl parties and no? Why not? Why do you?
I think there have been a lot of precursors that have given us warning that this was going to happen. We had SARS, we had MERS. I mean, there were simulations about this very thing, that this was coming. I actually was having a discussion about this with my kids, that I don't know if things are ever going to go back 100%. to normal in terms of even masking. Perhaps, it'll be that when another virus emerges, that we'll be quicker to don our masks to try and prevent this sort of a pandemic. But do I think that this is the last one? No.
Right. So this we could enter a new world where, I guess, just like the folks in the Southeast are like, they know when hurricane season is coming and they know the drill. That this will, it's another one, another whatever virus.
Right, here we go.
Here, you know the drill.
Yep.
Why do you think? Does it feel like that? I don't remember growing up that there were that many of these things. It seems like in the last.
No. I mean, I think that we've been very fortunate. I mean, everybody harkens back to the Spanish flu, but let's not forget polio. So, yeah. I mean, it's not unprecedented. I mean, similarly, kind of going a little bit off. I mean, I kind of wonder. In the same way that it took us so many years to recognize like a post-polio syndrome, harkening back to some of what we were talking about before, or, how long is it going to take us to really like know the full manifestations of COVID and a post-COVID sort of syndrome?
Yeah. Yeah. I mean, the point you made that someone may 20, 30 years from now may develop conditions that had something to do with getting COVID way back in 2020. Yeah.
Similarly to almost like a, I'm so sorry. In the sense, my colleagues and I have been trying to come up with like a, what does this sort of feel like in terms of, because it's on a much bigger scale, obviously, but, we had all these patients with like inhalational injuries after 9/11 from all the debris,
right?
And the EMS and the firefighters and all of our police and obviously the lay people, and it was almost like a time stamp, like on their lungs, and so I've been talking with some of my radiology colleagues. We kind of are very curious to see what are we going to see moving forward in terms of, you get a radiograph and you're like, those are post-COVID lungs, or that sort of a phenomenon, and more just like some of the complications that we're going to see. So.
Well, Adlah, you've been super generous with your time and very sobering with your description of what you've seen, and it's really a service that you're doing, obviously, when you're working in the hospital and with all the patients, but even coming and helping us kind of lay people hear more than just like what you see in the headlines or in kind of press statements and stuff like that. Is there anything else you wanted to share in terms of advice for civilians out there or suggestions for policymakers? Anything else that you want?
Yeah, no, I mean, I would just, get back to just please, wear your mask, do all the safety measures, common sense sort of things. I mean, I'll just kind of maybe end with this is that, when this all first started, I think a lot of us in terms of in the medical field were like, looking back, oh, I was sick in February. Oh, I hope I had it because I hope I have antibodies, and now we know that, 40% plus of people don't have antibodies like 8 weeks after an infection. And do we even think that those who have antibodies have any sort of protection from this virus in terms of a theoretical risk of getting it again? We don't know that, okay? And so we all kind of morphed from, we hope we had it to, oh, please, I hope I never have this because of what we've seen and what we've dealt with. And I know that the people have probably seen plenty of people on TV, physicians wringing their hands saying, you have no idea what we've seen. Like, you have no idea. You would never be cavalier if you had any idea. And I'll say that, but I know that it's hard for people to understand because, you've been in isolation, you've been going about your life, you probably don't know anybody who's had the virus, but it is continuing to infiltrate into the community. And I think it's a matter of time before you're going to know somebody who is affected. And you don't want to have that happen. You just don't want to have that happen. And my last word will be a shout out to all of the nurses and the respiratory therapists and the medical technicians and the cleaning staff and the staff that deliver meals to these patients within those hospital rooms. Everybody's been lauding the physicians, but let me tell you, you want to know who goes in those rooms again and again and again and again? It's the nurses. It's the respiratory therapists. It's the cleaning staff. It is, the people delivering meals. Okay. So we need to, I'm grateful for the appreciation that I feel like, as a medical professional I've received, but I really want people to thank those other people that they may know in their professional lives or in their community, because they are really, really risking themselves.
Yeah, I will second that. I mean, these folks are putting a lot at risk, and they are heroes, all of them. And so thank you for you and your extended team for everything you do, Dr. Sukkar. I really appreciate you helping us understand more what's going on. And I'm also heartened to hear that you are still going out there, and you're not kind of in a bunker.
No, we went camping last week.
Yeah.
We went camping. We were very socially distanced, but we camped and they had a blast. We've all got to take care of ourselves, as well, emotionally, physically, because, as much as we would all hope that this will just be over, please, we've got to conserve our energy and conserve our emotional health, because we're in this for a while.
Yeah. Well, I will put some links below to some resources. Are there any particular websites or places that you recommend your friends go to kind of learn about best practices or anything like that I can add to?
Beyond the CDC, I haven't really been recommending too many things beyond that. It's so rapidly changing. It's very hard even for those of us in the medical field to keep up with how quickly the medical side of it is changing. But, if people could just start with common sense, basic hand washing and masking, that'd be a great start.
Yeah, sounds like
hopeful that we'll see less flu.
Yeah, that might be a benefit.
Because we're all kind of racing for COVID plus flu, but if people are masking and hand washing and not touching their face, then maybe the silver lining in this is that we'll have less flu. We can only hope.
Yeah, that would be certainly a benefit. And I'll link. You mentioned the CDC. Do you are you confident in the information you're getting from the CDC? There's a lot of discussion now about, is it politicized?
It depends on what week you ask me.
What about as of now?
As long as they keep saying to wear a mask, I'm okay.
Good enough. Well,
and then support poor Dr. Fauci. We've got to support.
When you hear him speak, do you find him credible?
Absolutely.
Okay. Yeah.
I think he's very calm. I think he's very level-headed. I think he's been doing this for a long, long time. And I think he leads by example. Go look up pictures of him donning his Ebola gear when he was, I believe, 76. Okay? He's leading by example. Yeah.
He's walking a tightrope because he has to keep it real for the public, but also he can't
not be muzzled.
Yeah. So it's
he's in a very precarious sort of situation. So hopefully, people will continue to look for reputable sources of information. Facts matter.
Amen, sister. I feel you. This is the nerd zone. So we love data and we love evidence and logic, and hopefully all of us can use some of that to make good judgment decisions. And as a reminder, wash your hands, wear a mask, keep a safe distance. Just do those 3 things, you'll probably reduce your risk significantly, and also
in other countries. Look
yeah,
at other countries.
yeah, exactly. All right, well, with that, I'm going to say goodbye, nerds.
Goodbye, nerds. Thank you.